All right, yeah, so for those of you that might remember that this was a system change discussion that we had. We were trying to figure out, we've been doing a lot of proactive referral systems, getting the healthcare system to refer directly to the quitline. And usually there is some very initial enthusiasm for it. A lot of people responding, and we do trainings and all that. And then it kind of falls off, and there's not much that makes it very sustainable. So we had a project that we've been working with LADHS, the LA Department of Health Services, I guess, which they call e-consult. And it was sort of a similar thing where we're setting up a kind of an automated referral system that they could activate. But we were expecting that we would probably get this same kind of pattern of early enthusiasm and then a big drop off. So that was what we presented, and we had a number of recommendations that were made. I kind of summarized some of the recommendations here. There was some discussion about how other states had been able to build in an opt-out system so that everybody that came into their clinic was automatically saying through whatever paperwork they signed that they were saying, yes, it's okay to make a referral on my behalf. And that way the helpline or the quitline could go ahead and start just contacting anybody that had been flagged as a smoker. There was also recommendations to increase the touch to new physicians and staff. There's a recognition that there's high turnover rates in some of these positions. People might know about it, then they move on to another clinic, so you're really starting afresh, and there's not much, if you don't have a champion there kind of doing trainings on an ongoing basis, people can forget. There was a suggestion maybe to capitalize on times where, like, there's the TIPS campaign or something that's sort of got the public interest, and that might be a good time to reach back out to physicians and staff. And there was also some discussion about how to use some of the performance measures that clinics are already required to do, or the expectations that they already have written into their workflow, to capitalize on those as a way of saying, hey, here's a measure that you can evaluate in your clinic, which is how often a smoker is referred. And then the last one was to create some competition, like, hey, this other clinic is doing really well and you're not doing so well, as a way, as some motivation. So I wanted to give you a little update on what we did. No, back up there still, because I'm only on number 2. There we go. About what we did, what action we took. So the main one that we worked on was trying to implement a new workflow, and that's sort of related to the opt-out system. We have not been able to establish a true opt-out where just by signing into the clinic, they're making a statement that it's okay to refer them. We've been having to get more individual level consent. So we did have phase 1 where what we have been working on is integrating one of our staff members, and that's Carrie Kirby over here, into the LADHS system. So she essentially became a member of their system. And she was able to get a list of names and proactively call out to those people on behalf of LADHS and say, hey, you know, is it okay to make a referral to the helpline? And it worked really well. I'll show you the numbers in a minute. Well, maybe go on down so they can see the Becky, can you, there we go. So if you see the little blurb there at June of last year, that's Carrie. Okay, you can go back up. So, so it worked well to have somebody do that. It was very labor intensive, but at least it was centralized with one person, and there's no diffusion of responsibility. If she didn't do it, it wasn't done. Then we moved into kind of a phase 2, just trying to make the referral process much easier for providers, for the MA or the nurse or whoever it is that has contact with the client. And all they needed to do was ask the patient if they smoke and give consent for a referral to the helpline. And if so, then they check the box. And that was all that was required of the provider. Then LADHS can run a report, pull the referrals, and that would create an e-consult referral. Is that right, Director?
I have to create it, but yes.
Okay, so she gets the list and has to go in and create those, but she doesn't have to contact the client. And then the helpline staff, the California Smokers Helpline staff, can call the patient. We've had some success, and you can see that in the numbers down below in October, but still very few people are using that system, far fewer than we would like. So the second thing that we did really had to do with trying to get the word out, increasing the touch to new people and that various things. So, you know, there is a listserv, the emails went out, but it was an email that was kind of attached to other updates, so I don't think it was terribly effective. We are going to be talking to the primary care directors at the primary care director meeting later this year, in the hopes that maybe that would carry the message. And then, you know, in line with the idea of capitalizing on tips, the whole new vaping illness is really getting people's attention. So that is an avenue that we probably need to exploit. And that's probably going to be linked to the listserv and any other trainings that we have, try to talk about the new services we have for vaping. In terms of getting the word out, we've also speaking with the Associate Chief Medical Officer to see about getting on grand rounds, because we've heard that that is a good way to capture the provider's attention. But again, if the provider has to do very much, they don't. And if they have to remember very long, they don't. So it's still a challenge in terms of sustainability. The other had to do with capitalizing on expectations and performance measures. And we did have some early traction with that when, I don't know if you want to say more about the prime measures and.
Yeah, so one of the measures that people are often, one of the measures that they have to do is they have to assess for smoking rates, and they do. So they have high rates of assessment, but the problem is from assessment to then actually providing help, there's really no measure. So if they ask a person if they're smoking, then it looks like they're doing well. So most of the time, so LADHS, they wanted to be over 90. They're currently at like 93.5. So for the next cycle, they have to make it up to 95% for assessment, which they likely will do, but then they assess, but then then they're not measured on, do they refer, are these people getting help? So this list that Sharon was talking about for phase 1 is a list of people that have been marked as a smoker in their chart. So we know they're smoking, so they're getting this assessment, they've gotten it, but then no one ever does anything else with them until I call them. So there's sort of a disconnect where, yes, they may meet their measures, so they did really well and they assessed for smoking, but then they don't do anything with those people. So this list that I got of like 380 people, their measurement was high because they assessed them, but then they didn't do anything with them. So there is a disconnect that we may try to capitalize on, but it's difficult because they're not being measured on those advise and refer part, so they kind of fall off.
And I think that's something that that's well known in the healthcare provider area about how they want to try to work on increasing those rates, but they also don't want to shoot themselves in the foot by committing to high rates of those and then falling short. So, all right. So if you can move down a little bit, we have not tried. Becky, those slides. We haven't tried the competition method, although that seems to be fine. So the question was, you know, how well received were the recommendations? And I want to say that recommendations were very well received. Everybody believes it's a really important idea. And when we come together in a meeting and everybody's there, it's like, yeah, you know, gung ho. But again, you go out into your everyday work world and it's very, very busy and it's difficult to get it, you know, to get on the meeting agenda. We can send emails, but they don't always get read. So it's still a struggle. In terms of the system, were the colleagues open to the recommendations and the idea, again, they're all open to systems change, but it's hard to sustain the momentum. We're trying to increase the referrals. There are smokers out there, but the key is to figure out how to get them going. So are there any next steps that we've planned? So we're going to do the grand rounds, the primary care directors. Getting possible feedback to the providers who are referring, kind of a pat on the back so that if they have referred, that they don't then fall off and stop referring. Do more in the way of listserv emails, capitalize on the interest in vaping. And I think the other thing that we are doing, which is not listed here, is trying to find a way, using some of the funding that we have available, to provide nicotine patches, quick 2 weeks of patches. I know a lot of the other quitlines, that's a sort of automatic in terms of a service that's offered at the quitline, but that's not true in California. So we're hoping that that would at least help with the conversion rate, people taking the call and enrolling in the program.
One other thing that I'm going to jump into is not for eConsult LA, but for some of the other health systems that we're working with. We are also trying to do an opt-out system where they would actually just send us all of their smokers, so we would act on behalf of that particular plan. There's a lot of contracting, a lot of back and forth, a lot of security measures that go back and forth because we're sharing PHI. So we are still working. It's not listed on here because there hasn't been a lot of momentum and it's not with this particular group, but we are also trying to do more with the opt-out. But there's just a lot of pieces to that puzzle.
So, there's the graph. So you can see, you know, an initial burst of enthusiasm starts to flag a bit. Then we put out a email banner thing, and then it flags again. Then we have Carrie involved, and it goes back up, and then it flags again. And now we're trying phase 2, which is that one that's 21 people in the month. So hopefully that will be more successful. And that's it.
That's great. Thank you so much. That was a wonderful recap. And, you know, it's the data are an issue. And, you know, part of the project, we're asking for our health centers to report back on the advise and refer. And they'll all tell you it's hard. And a lot of them are having to pull that data manually because it's just not built into the system and it's expensive to change and, you know, everything else that goes along with that. So anyway, I think everybody shares your pain for sure. Yeah. Does anybody have any? Oh, I'm sorry.
No, I was going to say thank you for sharing my pain.
Does anybody have any questions or comments, or faculty? Amy and Frank, did you have anything that you wanted to ask about, or any additional information you wanted to share?
I was thinking, this is Frank, so I was just thinking, would it be worth it or possible for you to just, at the start here, to focus on particular kinds of doctors? So I'm thinking, you know, in my experience, pulmonologists are very receptive to all of this because with adults, most of the vast majority of their patients are smokers. So, you know, focusing on pulmonary medicine and maybe cardiology, because again, a lot of the people who are having heart attacks now in their 50s, 60s, et cetera, are smokers. So I think both of those areas seem to be, you know, very, very receptive. And then the other thing that, you know, Steve has always focused on is to not focus on doctors. You know, they're not the best people to refer in many cases. So maybe, again, if we're looking at this, you know, respiratory therapists in many systems that I've worked with are the people that are actually doing the referring. The cardiac rehab people in many hospital systems, again, they're doing the referring. So you might want to think about, number one, focusing on a couple diagnoses or a couple areas like that. And number two, maybe talking to, you know, the Respiratory Association or the, you know, Cardiac Care Nursing Association or something like that and getting them on board. And the other comment is that I have done, the grand rounds thing does work. I've done that many, many times. But you might want to think about trying to veer away from physicians so much.
Right. I would agree with that. I think we all would, because even the physicians might. I think one of the things that's a little unique with this LADHS is that they don't want us to go out to some people and not other people. They have a thing about, like, we want all the clinics all at the same time, but they're not our only source of this referral system. So I think your point is well taken.
Thanks, Frank.
Hi, this is Amy
Hi,
Spur.
this is,
Oh, I was just going to
hi, this
echo
is,
Frank's words there. If we can focus on within that workflow that those MAs, nurses that are, rooming the patients and are asking that assessment question about their tobacco use, if we can just capitalize on that, and as much as we can make it just standardized, just a standard of care that they're always, when they're asking about tobacco, they're saying, we're going to refer you on for treatment, you'll receive a call, and that's kind of that opt-out approach, because then the patient, has that authority to say, no, I'm not interested, but we want to make sure that we're providing that treatment, at least offering. So saying you're going to make that referral. So it's one extra step for the MAs or nurses that are rooming the patients. But, from our experience in Wisconsin, we have more MAs and nurses that are willing to do that than putting it off and kind of handing it off to the providers to do. So if we can look at that approach and just, again, trying to standardize that as much as possible.
I think that's a really good one. Where we've run into trouble is that in the health systems that we've been in, they're all willing to have the MA queue up the order, set it all up. So do the ask and even in the advise, and then here, is it okay, and get consent and queue it all up. But the doctor has to be the one to push the button. So I'm not sure why we keep running into that here, because I think your approach is a much better one. Yeah.
Yeah, and that's something to look into, because we do have health systems that then understand the need for this to go through, and it's not getting done if we're waiting on them. So if
and
that's
it's burdening to the provider. I mean,
exactly.
Unnecessarily burdensome. Yeah.
Yeah, so we do have some systems that the MAs, they do it all, and it makes sense within kind of their scope of practice to be able to send in that referral. Of course, they're not, addressing medications and any of that, but to be able to just send that in, that referral on their own without getting that signed off by the provider has really helped to move things forward too. So if you can look into that and see how that might be a possibility, that would fit within that role of the MA to do so.
Will do. Thank you.
And then Bob, did you have something you wanted to say?
yeah, I did. I understand the frustration with the fact that health centers in particular are focused just on whether or not they record whether or not the patient has a smoking disorder, and then whether or not they're referred, but they don't go on and measure whether or not it's successful. But one area where you might be able to get attention from the health center and docs and other providers there is around diabetes, because of the fact that 40% more likely to get type 2 if you're a smoker, and also the fact that smoking inhibits their efforts to control diabetes. And that's really a major push for HHS toward the health centers right now. So they're trying to get their patient population at least control diabetes and get HbA1 less than 9. So if you're trying to reach out and get docs' attention or get health center attention on the subject of smoking cessation activities, that might be one way to do it.
Great.
Great, thank you.
And just to be clear, I'm not suggesting that you just talk to pulmonologists or just talk to cardiologists, but I think, what we're all saying is maybe it's like a phased in approach. You focus on these, like diabetes and these other kind of diagnoses that we know have smoking has a profound effect on. You start there, get those healthcare professionals involved, then you move on to another group, and then slowly phase in everybody rather than trying to do everybody all at the same time.